And why should you know about congenital heart disease? Because there's about 2 million of them now in North America, so you're going to be seeing them a lot in your practice. And I'm going to go through a lot of cases and some common things that we see that cardiologists often overlook and how you may avoid those mistakes. So just for those history buffs out there, I'd remind you that in 1801, Lord Nelson put the telescope to his blind eye and said, "I see no ships." And hopefully you won't do this. This gives rise to the expression turning a blind eye. And when you're doing echoes, hopefully you won't be turning any blind eyes. And I'm going to go through then 6 things that I hope you won't miss in your practice and on your echo imaging. So this is all going to be case-based, and I'm going to begin with case number 1, and here's a mistake. Maybe we could turn the lights down just a little, please. So let's begin with a simple lesion, bicuspid aortic valve. As you know, it's one of the most common congenital lesions, but I want to remind you of the genetic implications and how important it is to screen first-degree relatives. And of course, you will remember the aortopathy that's associated with this bicuspid valve, the so-called cystic medial necrosis. So here's a case, a 36-year-old man who was transferred to our hospital following SVT. His father has a history of a dilated aorta, grandfather, bicuspid aortic valve, and a coarct, and had surgery. But neither the patient nor his brothers had had echo screening. And I draw your attention to the chest x-ray that shows not only a big heart, but also a really dilated aorta. So now he's in with his episode of SVT, and here's his echocardiogram. As you see in this long axis format, his LV is huge, both in systole and diastole, and you can see this aortic valve that looks a bit lumpy and is doming. And in short axis, you can see that there's some fibrosis and calcification, and it's a bicuspid valve with a raphe over here at the top. And velocity 3.4, mean gradient 30 across that valve. Ventricle not looking entirely happy as well as dilated, and as we turn our attention to the color, you can see there's important aortic regurgitation. Look how pulsatile that aorta is in the middle, and as you see on the right, that red flow going back, and that holodiastolic reversal in the descending aorta telling you that that's severe aortic regurgitation. So it was the SVT that brought him in. There's his aorta, 49 millimeters, so approaching the time when surgery would be indicated anyway for this valve. And so he needed a root replacement with a mechanical aortic valve. But of course, early on, because that ventricle was so big and not functioning well, his early post-op EF is impaired. And obviously, it would have been great to get him earlier than that. You can see how dilated this aorta was on imaging. So in a sense, the SVT saved him, and I'd remind you that the risk of dissection with bicuspid valve is about 9 times higher than the general population. And about 9% of first-degree family members have a bicuspid valve. In one series, almost a third. And another 9% have some other congenital heart disease. So it's almost 20% of first-degree relatives. And so really, in a sense, this SVT for this patient saved him before he had any further catastrophe, but still his EF wasn't normal. So screening first-degree relatives with an echo is absolutely key for your patients with bicuspid valve. Let's go on to mistake number 2. Here's a 65-year-old woman referred for a VSD and possible severe pulmonary hypertension that she'd been diagnosed by echo at home. And as you start to look in the perimembranous septum here, you can start to see a little bit of a dropout, and her LV is big, 58 millimeters. So is this a significant VSD? So we need to look a bit further, and there again in the perimembranous region, you can see this left to right shunting across the VSD. The RV is also slightly enlarged, and that VSD we're measuring here at approximately at least 6 millimeters in size, so certainly not very small. So we start to look at our velocities, and here you can see flow through the VSD both in systole and diastole, and we have a velocity of 4.7 meters a second through the VSD, which would suggest that the RV pressure was relatively low, so not much pulmonary hypertension. Here's an apical format. Now we've got apex down, so the RV is over here, and you can see there's at least a modest amount of tricuspid regurgitation, and you can also see flow through the VSD right here. And so we start trying to get a signal of the TR velocity, and that's what they'd got, 4.3 meters a second. So now they're worried about pulmonary hypertension, but is that the velocity through the VSD? So we start to look again, and here you can see the septal leaflet of the tricuspid valve is starting to get tacked down over the VSD, which it does. It forms an aneurysm of the membranous septum. That's how VSDs close. This one obviously not completely closed. And again, trying to get the TR velocity from the RV inflow view, and that's the velocity that they took, which is about 4 meters a second. But you can't do that because the VSD velocity through that jet is getting all tangled up with the TR velocity. That is not a clean TR velocity. So you turn your attention to the pulmonary valve and look at the pulmonary regurgitation, and there, even though it's faint, you can get an NPR of 0.9 meters a second, confirming that this patient actually has no pulmonary hypertension whatsoever. So remember, the VSD velocity was high, but do not get tangled up with the VSD velocity and the TR because they're so close together, and that TR jet is contaminated when the VSD is close to the tricuspid valve. So look at other things, check the PR velocity. This lady had a big LV, and when the LV is big with the VSD should be closed, which hers was. And the tricuspid valve had an annuloplasty. So another mistake, don't confuse those two jets and check the PR velocity. Number 3. This one I get very regularly, although I hammer on about it all the time. Causes of right ventricular enlargement. And this is a common phone call. I have a patient with pulmonary stenosis and a big RV, but the pulmonary velocity on echo is only 2.5 meters a second. What do I do? And the answer is you never get a big RV with isolated pulmonary stenosis. You get hypertrophy, but you don't get a big RV. So why have you got a velocity of 2.5 meters a second? Because of a shunt. Here you see an example of an ASD, and of course the answer is that you get increased flow, as you see in that white arrow, out through the pulmonary artery simply because of the left to right shunt. So you get that velocity of 2.5 meters a second just because of the left to right shunt. It is not pulmonary stenosis. So you have to find a shunt when you see the big RV, and of course transthoracic echo is very important, and I'm going to show you some ways to help you find them. But of course, if you can't find it, you have to keep digging, and you might need a TEE or some other imaging like MRI. Here's a classic chest X-ray of an ASD. So you have to look everywhere. Look at every window. That's my message. If it's not a secundum, look for sinus venosus. And if you can't find an ASD anywhere, look for anomalous pulmonary venous drainage, which can happen as an isolated lesion and make for a big RV. So explore every window, and I'd encourage you to look both subcostal as well as suprasternal. And I'd remind you, for example, that the sinus venosus defect, which is much harder to find on transthoracic echo, is posterior to the fossa ovalis, as you see here. So that makes it harder to find. And it's in the superior portion of the septum, and it's also associated with anomalous right upper pulmonary vein almost always. So it's a double volume overload for the right ventricle. So how do you find these on transthoracic echo? So here's an example. You can see in the short axis format, that LV is a bit D-shaped and the right ventricle is enlarged. And this one is also hypertrophied. Here in the apex down format, you can see there's some TR, and the RV again is dilated and is hypertrophied. And the TR velocity, there's some pulmonary hypertension here. The TR, even though it's faint, is 4 meters a second. So we're worried about pulmonary hypertension. So where is the shunt? And this is when you want to really dig in the subcostal window. And this is how you usually find them, often getting the patient to take a deep breath in. And as we're looking at the right atrium and the atrial septum, you can see there's a big area of dropout here. And this is the really large sinus venosus ASD that we can measure at about 1.4 centimeters. So that's giving you the big RV and the pulmonary hypertension, and the subcostal window is the way to go. If you can't find the defect, again, think about doing other imaging like TEE or MRI. Okay, mistake number 4. Never assume, because a surgeon's been in the chest before, that the complete diagnosis has been made. And again, I'd encourage you to always, even if you think this is a routine post-op study, just do a really comprehensive study, because things may not fit and things can be overlooked because maybe the surgeon didn't find absolutely everything. So here's another example. This is an X-ray of a 45-year-old woman who had a murmur heard when she was 21 and was found to have a secundum ASD, and that had been closed by a sternotomy many years before. And so you would think she should be doing okay, but in the last 3 years, her exercise capacity's been going down. And on exam, sinus rhythm, normal JVP, but the right ventricular parasternal impulse is prominent, and she's still got 2/6 systolic ejection murmur at the left sternal edge. And you might say on here that she may have some increased pulmonary plethora and perhaps some RV enlargement, as you see in this chest X-ray. So let's turn our attention to the echo. Has her ASD patch become dehisced? What the heck is going on? Why has she got the murmur? And why is she not doing well? So here's the short axis, and you can see here that the right ventricle is still quite large. Function is good. LV function is good. And so we have to figure it out. Has she got a residual ASD? Why hasn't the RV remodeled favorably? So again, we're zooming our attention onto the atrial septum. Again, this is apex down format. And in the area of the fossa ovalis, it looks a bit redundant, but we're certainly not seeing any significant color flow across where a secundum ASD patch has been. So again, why is the RV enlarged? So we turn our attention to the suprasternal window, and here you can see the aorta on the left, and in the middle, as you start to look, and over here on the right, you can see there's some red flow here lateral to the aorta. So here's the aorta in blue, but there is red flow heading north. And here we can delineate it a bit further, that there is something sizable way over here in the left chest that's got red pulsatile flow heading north. So what can that be? We put our Doppler signal in there, and we see, again, this low velocity pulmonary flow or low velocity venous flow heading towards the head. And as you see, this is going up, coming around, and heading down towards the heart. So what is this? This is anomalous left pulmonary venous drainage, and this is drainage from the left lung heading into a vertical vein, which goes into the innominate vein and round to the SVC. So this lady, although she had her ASD closed, has this huge amount of flow coming from the left lung. And of course, the surgeon wouldn't see that because this is over on the side of the chest while the surgeon was focusing in the middle. And of course, this requires surgical repair. And here what you do is you anastomose this anomalous venous drainage, the vertical vein, to the left atrial appendage through the left chest, and then you can resolve that RV volume overload. So again, I show you this case just to demonstrate that because the surgeon's been in there, things may be left, things may be unnoticed, and again, importance of going through all these windows, suprasternal, subcostal, and here's the answer that this lesion was overlooked and she required a second surgery to get rid of this anomalous venous drainage. Okay, mistake number 5. Here's a 30-year-old woman referred for evaluation of an abnormal chest X-ray. And here you can see her aorta is a little bit enlarged, 4 centimeters. She's a petite little body, only about 5 foot and weighs about 90 pounds. Left ventricular function, I think you'll agree, looks good. And she's also quite petite, and we always begin our imaging from subcostal, and we've got a nice view of this aortic valve here. Would everybody agree this is a 3-cuspid valve? So nice images. And we look at everything from the abdomen. Here's the aorta, and we're looking at a flow in the abdominal aorta from subcostal. We're actually getting good images. This too is from subcostal, the apical format. We're looking at that aortic valve again because we thought it was a little bit thickened for a young woman, and you can see that there's just a little bit of aortic regurgitation. But again, a good LV. And there's the velocity across the aortic valve, only 1.4 meters a second. But we've seen that her ascending aorta is a bit dilated, so we want to look at the rest of the aorta. And so again, suprasternal images are a bit challenging, but we want to look down the descending aorta. Is there any coarctation? And here's the velocity down the descending aorta, 1 meter per second, and we don't see evidence of turbulent flow. So I'd ask you, maybe we can have the lights up a little bit. What's the diagnosis? I've shown you everything you need to know. So the clue was, first of all, here's a chest X-ray, and you can actually see a figure 3 sign here and some rib notching. But nobody, of course, had ever felt her femoral pulses. And here's her abdominal aortic Doppler. And the aorta is small, but look at this flow. It shouldn't look like that. You've got a very slow upstroke and a slow decay. And a normal abdominal aorta flow should look like this, right? Brisk upstroke, rapid deceleration, and hers instead look rather like that, like a wriggly worm. And the problem is it's severe coarctation. But the mistake is I showed you a descending aortic velocity, right? And it was 1 meter a second. It's great when it looks like this at 4 meters a second for a severe coarctation. But the challenge is if you have a coarctation that's like this, that's so severe there's barely a red cell squeaking through there, when you're doing your suprasternal Doppler and trying to get down that little narrowing, echo can miss that very easily if the Doppler's not absolutely aligned. And that's what happened in her. Her coarctation was about 1 millimeter across, very, very severe. And so suprasternal misses it. You absolutely have to do abdominal flows always, otherwise you miss that diagnosis. So anytime you suspect it, think about other imaging and always remember your abdominal aortic Doppler flow. Of course, it would be great if somebody had felt her femorals. She had hypertension, which was very severe, which had gone completely unnoticed, very severe hypertension on 4 drugs. Nobody ever felt her femoral pulses, and her feet were always freezing. So the message from the echo perspective, always think about the subcostal abdominal aorta because the descending aorta may miss it, and think about doing other imaging like MR or CT. Okay, the last one, mistake number 6. And this is, I know how difficult it is to know about all the residua and sequelae of surgical repairs, particularly when they're complex. And of course, patients who have complex congenital heart disease should be followed in special congenital heart disease centers, but many are lost, and you'll be seeing, I'm sure if you haven't already seen, a lot in your practice. So let's focus on this mistake, and this is, of course, one of the most common cyanotic heart lesions, tetralogy of Fallot, and probably taking you back to medical school, I'd remind you that there's this big VSD and a stenotic lump of muscle between the RV outflow tract, sometimes also with a stenotic pulmonary valve. And so patients are cyanotic because blue blood can't easily get out the pulmonary artery, goes through the VSD to take the path of least resistance and into the aorta to make them blue. And we've been repairing this lesion since the 1950s, and typically the surgeon will close the VSD and resect that muscle so the blood can easily get to the pulmonary artery. But of course, since the pulmonary artery and the outflow of the RV is usually very small, frequently the surgeon will have to patch the RV outflow to make sure blood can get out the pulmonary artery, and that patch may frequently extend all the way across the annulus and out to the pulmonary artery itself. But here's a case, a 38-year-old man who had repair of tetralogy at age 3, and look at this chest x-ray, and the first teaching point is if the repair is good, the heart size should be normal. Obviously, it's not. This is what his doctor wrote. He was fixated on the RV enlargement and decreased function. I explained it's reassuring he hasn't developed pulmonary hypertension, and that the RV can continue to function fairly well as it doesn't have to generate significantly high pressures, but he's not feeling well. If he continues to have decreased RV function, he may progress to RV assist device and potentially a transplant. And the patient read this and referred himself. Here's his echo. You can see his RV, as we thought from the chest x-ray, is big. And his images are difficult because he weighed about 280 pounds. So we're trying to look at the outflow here and the pulmonary valve, but the TR velocity was only 2.4, so the RV pressure was around 30, so we're not thinking important pulmonary stenosis. So let's look at this outflow. Here's the aorta in the middle, the pulmonary valve, what's left of it, and there you see this to and fro flow, and here's the Doppler. 1 meter a second moving forwards. So the diagnosis is, shout out, wide open pulmonary regurgitation. Easy to miss, red flow going backwards. The Doppler's the clue. No stenosis with forward velocity, but look at this rapid deceleration back down to baseline. This is severe pulmonary regurgitation. This is why the RV is big, and when it's this big, there's a higher risk of VT and sudden death. Murmur of PR overlooked, completely overlooked on echo. This person couldn't get pulmonary hypertension. He was born with pulmonary stenosis. So the doctor overlooked everything, overlooked the echo, and what this man needed was a pulmonary valve replacement before the RV was shot. So my take-home points in the last minute: bicuspid valve, remember to screen the first-degree relatives. VSD, if the LV is big, it should be closed, and never confuse the TR jet with the VSD because you'll overcall pulmonary hypertension. If there's a big right heart, find the shunt. Don't assume the surgeon has made all the diagnoses at the time of surgery, and beware coarctation. It's easy to miss. Remember the abdominal Doppler. Think about alternative imaging. And tetralogy of Fallot. If your patient's got a good repair, heart size should be normal. And if the RV is big, always look for pulmonary regurgitation. So comprehensive echoes are important no matter what. Keep your eye on the prize. Don't get distracted. You may miss something big. Thanks very much for your attention.